Again, I'm Dr. David Kantrowitz. I'm a first-year orthopedic surgery resident at Mount Sinai in New York City. So some disclaimers for this talk before we start. There's no financial compensation for this for me. This talk is an original work of mine. All the photos that you'll see are photos I've taken. This talk's not directly affiliated with any of my personal affiliations like Mount Sinai or New York Presbyterian Columbia Hospital. All the patient cases presented are real, and all the patient like HPI protected health information is anonymized. Some images are graphic, so if that's not your thing, just kind of like viewer discretion is advised, look away. All right, so a little outline for the talk. So first I'll tell you a little bit about myself, why I chose orthopedics, a background on what orthopedics is as a field, some patient cases, we'll have 4 of them, a little bit about like the journey to becoming a doctor and some of my tips for you guys when I think back to like when I was in your shoes, and then a Q&A session. All right, so about me, I was born with congenital heart defects, which is why I always wanted to be a physician. I have a VSD, which is, if you guys are in medicine or studying it at all, it's a ventricular septal defect. I always grew up going to cardiologists and I always wanted to be a cardiologist. That kind of transitioned to wanting to be a cardiothoracic surgeon and then ultimately an orthopedic surgeon. Kind of made that transition and we'll talk about that. I grew up in New Jersey and now I live in Manhattan and I go to residency at Mount Sinai. My high school was the Bergen County Academies. It was a magna school. So I actually was in like an academy for medical science. So I was studying medicine kind of early on. I did my undergrad at Duke. I studied biology and then I went to Columbia for medical school and I'm at Mount Sinai now for residency. All right, so why ortho? So for me, in med school, I spent some time in the operating room, mostly in cardiothoracic surgery, but I just love the OR. I love like the project oriented nature of surgery, starting something, finishing something, very goal oriented. It's a team sport in the operating room. And the surgeon is the commander in chief of that ship. And I just thought that was really cool. I love being the agent of change for the patient. So rather than just prescribing a medicine and the medicine does the work, as the surgeon, you really do the legwork to make the change happen. I love my colleagues in orthopedics. This is kind of stereotypical of the field, but I met some co-residents in the gym at my medical school and I was bonding with these guys. I thought, they reminded me of myself and I really like my co-residents, both the men and women in orthopedics, I think are awesome. The patient population for ortho is really cool in my opinion. It's mostly healthy people who are advocates for their own health. So where in a lot of the internal medicine fields, you have patients who kind of have a lot of comorbidities, morbid obesity, heart disease, they smoke, they drink. Orthopedics has a lot of healthy people who are like athletic and they want their mobility back and they're hobbled and hampered by an injury that you have the power to fix. And then when you fix them, they go back to that active way of life, which, I really appreciate. The pathology is cool. I'm into sports, weightlifting, and I think, so I have this picture here. I'm a big Giants fan. When Saquon Barkley tore his ACL, I actually watched the game live and I kind of could see it happening. And I think that pathology of sports injuries is very cool. And then the acuity. So right now I'm on a trauma rotation out in Queens and the acuity is really awesome. So you're seeing these patients right away. And a lot of times, like for example, I'm getting a page at 3 a.m, I'm running to the ER and I'm seeing someone whose bone is sticking out of their skin. And it's all about the acuity of managing that right away, which is very exciting. So a little background on orthopedics. So in Latin, it comes from 2 words, so ortho and pedia. And so ortho means straight or correct, like orthogonal, or your orthodontist straightens your teeth. And then pedia means children, like pediatrics is children. So it originated in the 1800s as a field for correcting or straightening skeletal deformities in children. You can kind of think about like Forrest Gump when he's running with the braces on his legs. So that's like kind of how the orthopedic field began. And what we do, we treat injuries, deformities, and disorders of bones, joints, muscles, nerves, and connective tissues, as well as some soft tissue tumors and bone tumors. Ortho has a lot of overlap with rheumatology. So treating like ankylosing spondylitis, rheumatoid arthritis, those kind of conditions. Plastic surgery. So plastic surgery also covers hand. So ortho and plastics both can do hand surgery. Neurosurgery for the spine. So neurosurgery and orthopedic surgery both cover spine. And then PM&R, which is like physical medicine and rehabilitation. And so that's kind of like the non-op orthopedic stuff. And that's a field you can go into also in residency. So what do I do on a daily basis? So as a resident, I see patients in the emergency room with acute orthopedic injuries. I reduce and cast broken bones. I was doing that last night at about 2 a.m. I reduce dislocations, so like dislocated shoulder, dislocated hip. The hip is harder than you think. I have to like stand on the stretcher and like both arms pulling up as hard as I can to get the hip back in. Lacerations, we repair a lot of lacerations, especially hand lacs. Drain abscesses if they are in orthopedic regions. So for example, in this middle photo, I guess you guys can see my mouse, right? This photo here is an elbow. It was like medial elbow over here. And I drained that abscess, cut into that, and it like erupted. And we operate as residents. And we operate more and more every year. It's a 5-year program for orthopedic residency. And I'm in my first year. The picture of me on the right over here is doing a total knee replacement on a cadaveric knee. So that's a dead body that was donated for science, and me and my co-residents there are practicing learning a total knee replacement with an attending. And then this picture is what's called an X-fix, or an external fixator, which is what we use to keep fractures stable until we can fix them definitively in the operating room, usually when the soft tissues are not like stable enough for surgery. So if there's a lot of swelling, like you can see here, people have diabetes, or that, you know, they have a big wound and we don't want to operate because we think it'll get infected. We put an X-fix on first and then we'll operate later. Okay, so we can go through some patient cases now. So our first case, HPI is the history of present illness. I know a lot of you are in high school or college, pre-meds. So I use some acronyms in here and I'll explain them to you because I think it's interesting for you to learn what they mean. You may see them later in your path. So HPI, the history of present illness, a 16-year-old male. SP is status post. So status post foosh, which is a fall onto an outstretched hand during a soccer game. So he had a right wrist swelling and what we call a dinner fork deformity. So you can see here, there's swelling a little bit proximally here and distally here. And this shape is kind of that, like, you can imagine a dinner fork is bent like that. So we call that a dinner fork deformity. TTP means tenderness to palpation, or tender to palpation. So painful when I pushed on it. Painful ROM is range of motion. So as I said to him, you know, can you bend your wrist back and forward? This kid was screaming at me. And then motor and sensory exam was normal. So testing for all the different nerves in the hand, I have him do a few different tests. I'm not going to go through them all, but to test for the radial nerve and the ulnar nerve and the median nerve, got to make sure everything's intact and he can move all his muscles. And then in terms of the vascular status, we check for pulses. We check for a radial pulse, an ulnar pulse. And then capillary refill is when you squeeze the edge of the finger, it turns white and then it turns pink again. That should be less than 2 seconds. And that's like a proxy for good perfusion. So neurovascularly intact, has this deformity. So when I see this, I kind of know what it is. But obviously we're all new and learning here. So these are radiographs of the wrist. Okay, so the right wrist, this is what we call an AP, or an anterior to posterior X-ray. This is the radius, this is the ulna, these are the carpal bones, this is the hand. So you're looking at the hand like this. And then this is a lateral, so you're looking at the hand like this. And then again, you can see the radius and the ulna. And so this doesn't look normal, the wrist is shortened. This piece here has kind of fallen down. You can't see where, because this is only in one plane. So then you turn it sideways and you see that this piece is here and it's fallen off. What we say, this is the dorsal side of the hand and the arm, and this is the volar side. So the shaft piece is volarly, and then the little head piece, the distal piece, is dorsally. And so this is a distal radius fracture. The name is specifically a Colles fracture. So a Colles fracture is a dorsally displaced distal radius fracture. Distal radius fracture is the most common fracture actually in orthopedics. I see these all the time. So with the hospital I've been at for the last month and a half, I've probably done 15 to 20 of these reductions already. This is my toolbox, I like to say. So I have some Acrylex. I hang the hand up on an IV pole by the fingers, and then I hang another Acrylex at the elbow and the antecubital fossa. And then attached to that Acrylex, I put this weight, actually. This is about 15 pounds. And I hang that down there, so that pulls the arm down while he's attached at the fingers. And the reason I do that is because I need to lengthen the wrist. So you can see here that it's short. This piece should be up top here. So in order to get that length back, I hang the arm for a while. While it's hanging, I'll do an injection with, as you can see here, this is a little vial of lidocaine. So like 5 to 10 cc's of lidocaine. We call it a hematoma block, which means you inject the wrist wherever you see the hematoma. And that's usually close to the fracture, which will help them with pain. These guys are plaster, which I use to make the splint. And then this stuff is web roll, which is like soft cotton that you put on the skin before you put the plaster on to protect the skin. And then this is an ACE wrap. So I get all this stuff set up, go see the patient. He was a pediatric patient, and classically, like young patients have poor pain tolerance. So I had the ER doctors do sedation with IV ketamine. So he was basically asleep. He was like semi-conscious. And then, so the C-arm is like a portable x-ray machine that I bring into the room with me and set it up. So as I'm doing my reduction, and the reduction technique, we say, recreate the fracture. So because you fall on an outstretched hand like that, you bring them back, you try to get that little dorsal piece free. And then you, with your other hand, I only have one hand to show you, you bring it back and you push that piece over the top back into place. And I'm taking x-rays with the C-arm while I'm doing this, so I know when it looks right. And so here you can see it looks better. This is the A to P, looks better than this, but not perfect. And then this one looks a good amount better than this lateral. So I finish my reduction, I do my splint, and then I send him for final x-rays. So this hard white stuff on the outside is the plaster. The kind of squiggly lines are the soft cotton stuff underneath it, pressing into it. And so here you see, this looks what we call, this is like anatomic. So the height is back, the radial height is back. It should be a little higher than the ulna. The cortical contours are great. The radial slope is good. So compared to this original one, it now looks like this. And this isn't a perfect lateral. This is an oblique x-ray, but you can see that there's no more dorsal displacement. So looks pretty good. We'll see them again in like 1 to 2 weeks for follow-up, because sometimes these fractures, even though I have it essentially perfect now in a splint, you know, kids fall, they hit their arm on stuff, it can move. And if it moves, you can lose that reduction, and you would want to know that, because then at that point you would probably go in and operate to get definitive reduction, because this is a young guy, he's playing soccer. You don't want him to have like a crappy wrist for the rest of his life. So you got to check on these patients, make sure that they're healing well. Okay. So second case, the history of present illness. You have a 20-year-old female who is status post a fall from 50 feet during a suicide attempt, which very sad. Luckily she lived. She landed on her left side. So they paged me at about 2 in the morning. I came down to the ER. She was intubated and sedated at that time. Her left leg was shorter than the right, so like a leg length discrepancy. It was held in ER as external rotation. So they called me and they said, hey, we think this pelvis is an open book pelvis. So there are some pelvic injuries where the pubic symphysis becomes open. And then there's an implication that behind there, this big posterior venous plexus in the pelvis can shear, and then you can bleed out into your pelvis. So there's some compartments in the body that you can actually bleed out into and die. Like you can exsanguinate, and the pelvis is actually one of them. So we have these things called pelvic binders that lock down the pelvis to try to clamp down on that bleeding. The ER residents had already placed the pelvic binder on there before they called me. So I went to see the patient after I looked at the imaging, which I'll show you in a second, but the pelvis was actually stable to my rotational forces, which was a comforting finding. She had good pulses, good cap refill. I couldn't do a nerve or motor exam because she was unconscious. So I couldn't say to her, wiggle your toes for me, do you feel this? So this is the first x-ray that I saw. So this is just an anterior to posterior x-ray of the pelvis. Everything in radiology is flipped, right? So this is actually her right hip and this is her left hip. So what I see here, the first thing that my eye goes to is this guy. So you can look at the femur here versus the femur here, right? This is unaffected. On this side, on the contralateral side, something doesn't look normal. The femoral head looks like it's kind of fallen down a little bit. And that's because there's a femoral neck fracture in here. You would need better imaging to exactly classify what this femoral neck fracture is, but it's probably displaced based on the fact that the head looks like it's fallen down. You also see potentially something going on here in the pubic ramus near the symphysis, and then something going on over here. So we got a CT scan. Okay, I think I should be able to play this. Okay, this is gonna be quick and I'll do it again. But so you're looking, this is an axial CT of the pelvis. So an axial cut means through the body this way. So imagine the patient is laying down in the scanner and their feet are out towards you and you're looking through the feet into the body, okay? So this is your right leg, this is your left leg, because again, you're looking into the body. And then we're starting at about up here, and this is the CT abdomen pelvis, and we're going down. So play it again. So this is your sacrum here. There's a little something going on there. Then you come down, you're gonna see the hip soon. So this is the acetabulum, this is the femoral head. Right there, something going on. That's our femoral neck fracture. And then right there, I can pause these cuts. Let's see, sorry guys. Perfect. So in our sacrum, you can kind of see starting here and progressing through, you have a sacral fracture, okay? And to me, this looks like a compressive fracture, which matters because it talks about the type of injury. And then go down a little bit, acetabulum, this is the acetabulum, this is the femoral head. Your hip is like a ball and socket joint. And then here, you can start to see the fracture. So this is the femoral head, this is the neck, and you see a nice fracture there. So that's probably a subcapital or a transverse femoral neck fracture. It's completely fractured, as you can see. There's a good shot, hang on, right here. It's all the way through, and the head is a little bit displaced. So that's gonna need fixing. And then here, this is now the pubic ramus. You see a little fracture here, like an oblique pubic ramus fracture near the symphysis. So this is your pubic symphysis, which is this right here. And so again, this matters because they were worried that she had an open book pelvis with a potential bleed. They called me, they said she's tachycardic. We put the pelvic binder on, we were worried she was bleeding out into her pelvis. As soon as I see that CT, I know that that's wrong. And I know that that's wrong. Oh, here's some, these are coronal cuts. So coronal cuts on CT or coronal means crown. So like you're wearing a crown, it goes this way through the body. So this is like you're looking at the front. So here's your sacral fracture, here's your femoral neck fracture, and then this is your pubic ramus fracture, okay? So when you have a compressive sacral fracture, and then you have a ipsilateral pubic ramus fracture, we call that type of injury an LC1. Orthopedics has a lot of classification systems, many of which I am still learning. This is one with which I'm familiar. And they're important because they talk about how injuries happen, if they're stable or unstable, severe or mild, and how they need to be treated. And they fit into the schemas. So when you have a pelvic injury, you can have it one of two ways. And this is the Young and Burgess classification. You can have an APC, which is an anterior to posterior compression. So anterior, posterior. So that's when your pelvis goes like this, okay? That's more of a shear force. You can have a lateral compression injury. So that's you taking your pelvis and something's hitting it. So she fell and landed on her left side. So it's much more likely that she had a lateral compression injury. And then if you look here, you have this sacral compression injury, sacral compression fracture, and then an ipsilateral means same side, contralateral means other side, ipsilateral pubic ramus fracture. So she had these two things. This is exactly what that CT looked like, 1, 2. And so this is an LC type 1 injury. And this is classically a stable injury that does not require surgery. And it is almost never associated with a massive pelvic hemorrhage. These ones are where you have pubic symphysis diastasis. So the pubic symphysis is blown out wide. So as soon as I saw the CT, I knew that she didn't have this type of injury. So I came down to see her, took the pelvic binder off. Her vitals stayed stable. There was no bleed. In regards to the femoral neck fracture, you have to fix that. So this is what we did. Left hip in orthopedics, this is a common acronym. ORIF means open reduction and internal fixation. So open surgery, you reduce the fracture and you fix it. So this is a sliding hip screw construct. So the fracture was here, you get it out to length, you get it reduced, it looks nice, you throw that long sliding hip screw in there, one extra interlocking, a couple distal down here. And that's a pretty nice looking construct for her. In femoral neck fractures in older people, we'll oftentimes do arthroplasty or joint replacement. So we'll do either a hemiarthroplasty, which means you replace half the hip, typically just the femoral side, or a total hip, which like a lot of people's grandmas might have had, and that's where you replace the acetabulum and the femoral head components. But that has much worse mobility and range of motion. And this girl is 20 years old. So we wanted to give her the best shot at like having a normal hip going forward. And so this was the best option. Okay. So third case, this is a 40-year-old man who had an electric saw injury. So he told me he was trying to make a cabinet. His wife was there with him. And he was cutting wood and then he slipped with the saw. So he had a partial amputation of the distal phalanx of the finger. The tip was sensate, meaning what was remained, he could feel. He could flex the digit. The nail bed was intact, which is important. And then there was not really any bone or tendon or nerves exposed that I could see. This picture is a little bit graphic, just a heads up. So this is what his finger looked like. Pretty clean cut. The nail bed here is intact, which so the eponychium and where the nail bed originates from needs to be intact. Otherwise, the nail won't grow. People like to have nails. Nails serve functions. Sorry if you guys can hear that background noise. That's New York City. All right. And so his nail will grow. It'll grow kind of oddly, but it will still grow. And then on the front of the finger here, this might have been the tiniest bit of bone. I kind of cleaned it up. So basically, when you have these partial amputations, you have two options. You can let them heal by what we call secondary intention. So primary intention is like you close a wound in the OR, you put the skin edges right together. It's a clean incision, it heals perfectly. Secondary intention means like it heals with granulation tissue. So like you run, you fall, you scrape your knee pretty bad, you're not suturing it together, but granulation tissue fills in. That's secondary intention. So if there's not really bone or tendon involved and there's less than 2 centimeters of skin missing, which his was, you can just let that heal. And so you need to put on a moist dressing. We have some things called Xeroform gauze. It's like tacky yellow stuff that I would typically use. He actually brought me in the fingertip that was cut off in a little bag on ice. And so he gave me the tip. And then I took that, I kind of like debrided off some of the fat and from the fingertip. And then I put that skin back on the finger. And so we call that a biologic dressing, which is kind of like the best dressing you can give to keep the tissues moist. Had there been a ton of bone sticking out, tendons involved, or just way too much skin missing, you would operate on this. And you can either do a revision amputation where you cut more of the finger off and then close the skin as a flap, or you can use a skin graft, which plastics likes to do. So I, like I told you, put the skin tip that he brought me back on the finger. And so this is not going to stay. This is going to die. This skin is not attached to any blood supply. So I told him the skin is going to turn black. It's going to die. But then underneath it, we'll have new skin growing. So that was a fun one to do in the ER. It was cool. Last patient case is a 50-year-old man with a history of type 2 diabetes who presented after twisting his right ankle and falling down the stairs. So on exam, he had a very, very swollen ankle on both the medial and lateral sides. So those are common terms. So medial is on the side like closest to the midline, and then lateral means on the outside. So on the inside part of his ankle and the outside, very swollen, little black and blue, really painful to touch, really painful range of motion. But motor and sensory was good, pulses were good, capillary flow was good. So these are the x-rays that I got. And so again, this is an AP, anterior to posterior of the ankle. This is a lateral of the ankle. On the AP, you can probably make out over here, you see a little fracture line. And you can see that through here. So this is the tibia, this is the fibula, those are the two bones in the lower leg. This is the talus, and then so this is your ankle, and then down here is gonna be your foot. The tibia looks okay, and you can see through it. This is the fibula. You see that kind of oblique fracture line that you see here. So this is, again, AP lateral. So this is the side of the ankle. So I'm kind of thinking, what do I do here? He has this isolated fibular fracture. So again, with classification systems, you have to know for ankle fractures, we have the Laude-Hansen classification system. So I'm not going to get into too much detail, but this classification system goes by the position that the foot's in at the time of injury, and then the force and direction of the injury. The most common one is this guy. supination, so your foot is supinated, and then external rotation force is the injury. These are kind of the classic fracture patterns that you get. So with this one, the most common, which is what I suspected he had, because the fibular fracture in this fracture type usually goes from antero-inferior, which means front bottom, to postero-superior, which means back high. And so you can kind of see this little fracture line right here looks a lot like this. So that's why I suspected it was a supination external rotation injury, along with it being the most common. Something you'll hear in med school a lot is common things are common. Like your patient in the hospital has cough and, what do they have? It's probably pneumonia. Common things are common. So SCR, that supination external rotation, there's different stages of what ligaments fail and how the injury progresses. If it's a stage 2, you have an isolated fibular fracture. If it's a type 4, you also have this is called the medial malleolus. So on your ankle, if you feel your ankle right now, you have like a hard bump on both the inside and the outside. So it's a medial malleolus and the lateral malleolus, medial mal, lateral mal. And so a medial mal fracture means, or you can have, you can't see ligaments in x-rays and stuff, but the deltoid ligament runs on the medial side of the ankle. If the deltoid ligament is damaged or the medial mal is fractured, that means that your injury force started laterally and went all the way through and exited medially. That's important because between these two bones, between the fibula and the tibia, is what we call a syndesmosis, which is kind of like a ligamentous joint, and it's important for ankle stability. So the way that I check this, because on his x-ray, you don't see anything over here, right? If I saw the fracture there, then I know the syndesmosis is involved and it's an unstable injury requiring more treatment, but he didn't have that. So we get what's called a stress external rotation view. So I would go down to x-ray with this guy, I take his foot, I internally rotate the leg, then I externally rotate the foot and dorsiflex it, which is a very, very uncomfortable position to be in when you don't have a fracture, especially when you have one. But I tell the patient it's going to be for 10 seconds while we shoot this x-ray. So do that. And then what you see here, we call this the medial clear space. So this is between the medial aspect of the tibia and then the talus here. And more than 4 millimeters of widening is considered unstable. Also, you can go look at their contralateral side and see what's normal, because everyone's anatomy is slightly different. So you can see what's normal for them. So this, we call this opening up, like, oh, the medial clear space opened up. It's an unstable injury, even though there's no medial mal fracture. The deltoid ligament here is probably not intact because as you're pulling, the space opens up. So that needs surgery. There have been studies that show that these injuries do pretty similarly in terms of functional status down the road, whether you put them in a cast or do surgery. But surgery gets you kind of back on your feet faster, gets you out of immobilization faster, definitive fixation and healing. Also, depending on your patient and how compliant they are, if you think someone's going to stay in a cast and actually not walk on their ankle for 6 weeks versus if you think they're going to kind of just disregard what you said, then you might prefer to do surgery. So we did surgery on this guy. All right, those are all my cases. Now I briefly just want to talk about kind of the journey to becoming a surgeon physician, kind of getting to where I am now, because I remember when I was where you are and I felt like I had a very long way to go. So if you're at the high school level now, doing well on your test, your SAT or ACT, whichever one you prefer to take, I think it doesn't really matter at this point. I would say the SAT tries to trick you, but time is not an issue. The ACT has a lot more questions per amount of time, but it's a lot more straightforward. So those are kind of like, you can pick and choose which to take. Do as much medical and volunteer experience as you can, which I know during COVID is really tough, which is why this program is fantastic to kind of get you guys this opportunity. I spent time in the emergency room at some local hospitals when I was in high school, and then get in contact with colleges and pre-med programs. So you can email whatever school, Brown pre-med program, you can find it online, email them, hey, I'm really interested in your pre-med program, kind of just engage with them. I think that goes a really long way. If you're at the college level in your pre-med, obviously crush the MCAT, do research. I think basic science type work, for whatever reason, med schools look the most fondly on. Get into contact with med schools. I did that. I was in contact with Columbia and I went to Duke, so I was also heavily considering Duke's med school. but like talk to people there, get your name in the door, ask for more information, write a really, really good personal statement. This matters a lot for getting into med school. And then good letters from your science professors. Also, it's not in here, but make sure your science GPA is solid. So if there's going to be a class you slack on, don't let it be organic chemistry. And then once you're in med school, to try to get into orthopedics or a surgical residency, you got to do all your boards exams, the USMLE Step 1, which I don't know if people know this, but as of, I think it'll be 2022, it's actually a pass-fail exam, or it might be earlier than that. But when I took it, and right now still for people, this score matters like a lot. It's the equivalent of the MCAT or the SAT, but for getting into residency, but they're converting it to a pass-fail exam. Do well in your clinical rotations, try to get AOA, and then do some research in the field you want. So I published like 5-6 things in orthopedics prior to residency, and then also good letters from surgeons you worked with and stuff like that. So that is my presentation. Happy to answer any questions. Don't be shy, put things in the chat. There's no stupid question at all. I know a lot of this was complicated and probably stuff you've never seen before. So I'm happy to answer anything that you have about orthopedics or my personal journey. There's nothing I won't answer. And then you are welcome to connect with me and send me questions, or if you need advice on stuff, the best way to reach me is Instagram. My Instagram is @doctor.dav. Couldn't get the E or the ID, it was taken. But you can send me a DM. I'm usually pretty responsive on there. So thanks, guys.
So right now we're opening up for Q&A, if that's okay with you.
You got it.
Rosie, do you want to ask the first question?
Sure. So we have quite a long list, but our first question is going to be, how do you deal with stress?
That's a good question. Let's see. Can I see this chat too? I'm trying to figure this out.
Yes, you should be able to.
Okay.
If you stop screen sharing, I think it would be easier for you.
That's probably it, yeah. Okay, wow, 65 chat things. Okay, stress is always going to be present. So I would say the best way to deal with it is to learn to live with it. So I've struggled with insomnia and anxiety a little bit in college. I have things better under control now, but you just don't be too hard on yourself. It's a really, really hard path. And you just kind of have to like, the ends will justify the means, but you should try to learn to enjoy the means. So just don't take everything too seriously. If you get a B in a class, like you will still be fine, but work hard. And again, just like you got to find ways, however your stress manifests, just figure it out, like what you can do to counter that. If you can't sleep or you can't eat, or you just feel like whatever, kind of figure out a way, meditation, breathing exercises, exercise, things you like to combat that. But it is just something you're gonna have to learn to accept.
How hard do you find it to balance your personal life and your like professional life?
That's a good one. It is pretty hard. It got gradually harder. So college, it was okay. I was still the person that went out the least of my friends. You know, my friends who went to banking were going out like 3-4 nights a week, and I would be lucky if I got in one. But again, you come to accept that. And then in medical school, it kind of comes and goes in waves. Sometimes people didn't see me for like a couple months, and other times, other rotations that were a little bit lighter, I would see people. You just have to take advantage of your free time. So like I've been on night shifts, and then I'll wake up in the middle of the day and I try like just to short myself on sleep a little bit, even though I'm tired, and then go get lunch with a friend or go to the gym, like make sure my personal life is intact, you know, go home and see my parents in the suburbs. Like those things are still really important.
So this question is pertaining to case 1, I believe. So the question is, what was the benefit of having him partially sedated rather than fully sedated?
So that's, so the sedation is for pain control, because this really hurts with adults. We'll give them morphine, sometimes an anxiolytic like Ativan or a benzo if they need it, and they can usually tolerate it. It's still really painful. The younger kids, like as soon as I touch the wrist, they start crying and screaming, and so they need sedation. IV ketamine is a good drug. It's kind of like twilight sedation. Full sedation, like anesthetic sedation with propofol, would require intubation with a breathing tube. So that's like a whole different level. So you're not going to intubate someone with a breathing tube for my like 30-minute reduction procedure. So ketamine keeps him like barely lucid. He doesn't really know what's going on. Can't really feel the pain, but he's breathing on his own. We have him hooked up to a monitor to monitor heart rate, breathing, and everything. And an ER attending is with me doing it, but like, you don't need a breathing tube.
How has COVID-19 impacted your daily life in the hospital?
Yeah, so I wear an N95 and a face shield most of the time. I always wear the N95, the face shield. If I have my glasses on, sometimes I won't wear the face shield, but I usually do, which is really annoying because patients can't hear you as well. They can't read your facial expressions when I'm trying to offer like a sympathetic smile or something like that. No one can see my face. And then the face shield with my glasses like fogs up all the time. All that, those are small nuisances, but they are annoying. I would say the biggest thing is just like feeling like I potentially am unsafe to others, you know, trying to go home and see my family or go to see friends. People are a little worried. Like I went to see my family, I had to get a COVID test because my sister's pregnant and my grandparents are older. And, you know, it's kind of like am I a carrier because I work in the hospital in still what's now becoming another hotspot as the virus kind of increases in New York. So, and that's not to say that if things don't get worse, because this trajectory that we're on is a little scary, they may ultimately, if they stop elective surgeries, a lot of orthopedics comes to a halt. And then I might be relegated to ICU care or like the proning team that like turns patients over because they breathe better when they're prone with COVID. Hopefully that doesn't happen, but it may.
So our next question is for case number 2. Do the screws stay in or do you take it out eventually?
The femoral neck fixation,
Yes.
that'll stay in there. That's a fixed construct that'll stay in there. You wouldn't take that out unless there was some kind of a hardware failure or problem. Some things like the lateral, like the fibula plates that we'll put on, people can feel those, or clavicle plates, and then eventually you might come back and take those out if people can feel it and they're bothered by it. But otherwise, you would usually leave it in.
This pertains to case number 3.
Mm-hmm.
Did the finger injury have any worries about nerve damage?
So yeah, I mean, as soon as you see that, you're wondering if there's nerve damage. But nerves, you know, they originate right at the spinal cord and they move to the periphery. And so, you know, it's cut off here. Had there been a laceration, but the finger was still on, my bet would be he couldn't feel the tip, but there was no tip to not feel. He could feel everything proximal to it because the nerves come up the finger. So, I mean, I checked. I said, do you feel me here? You feel me here? He said, yes. And then that's kind of good to go from there.
Did you get shadowing before you applied to med school? If so, how? And did you do any research in your undergrad?
I did shadowing a little in high school. My high school had a great program where I shadowed actually at Columbia as I was a senior in high school, and I went every Wednesday to the OR with a cardiac surgeon. But that's rare. I did some basic emergency room stuff too. And then I did research as an undergrad in psych, and then a little bit of basic science stuff in some cancer lab, pancreatic cancer stuff.
What are some academic lessons from your undergrad that helped you prepare for your residency?
From undergrad for residency. So particularly in orthopedics, physics matters a lot. And so it's funny because it's not my favorite subject, but I do think back to some of my, you know, physics lessons that I learned about vector forces and rotational forces and things like that. That comes into play a lot. It's just, you learn to work hard, you learn to balance stress, you learn to balance your personal life and your professional life. Those lessons all carry through. Like my pre-med curriculum at Duke was rigorous, and it taught me I had to like stay in on the weekends and study for 12 hours in the library, which is stuff that I did in med school and then occasionally stuff that I do now. So.
So the next question is, I'm sorry, I just lost it. This one's for case number 3. Did you have a picture of the finger after it healed?
No, so I didn't see that patient when he came back, unfortunately. He followed up in hand clinic with an attending, and they would see it and decide that if they needed more care, like a further operative treatment, or it healed okay. Unfortunately, sometimes I get that nice like longitudinal care where I treat someone and then they come back on a day that I'm at clinic, but I don't go to hand clinic, and so I didn't see that guy, unfortunately.
How do you persist through imposter syndrome, and do you have any advice for people who's going through that right now?
So in med school, I didn't really. I'm a pretty confident person, which is to my benefit with imposter syndrome, but also can lead me to maybe make more mistakes because I think I know what I'm doing. Now in residency, I definitely have a little bit of imposter syndrome where, I'm a new intern. I started my orthopedic trauma rotation in October. And on the first day, they were like, here's your pager, strap it on your waist. And then, oh, there's a fracture in the ER, go see it. And I'm like, I don't know what to do. Um, but the learning curve is so steep, but you move up it pretty fast. And so I would say after the first few weeks, seeing things with repetition, having my senior residents help me, learning, reading about it, you master a couple things like the ankle fractures, for example, the distal radii, for example, are things I feel comfortable about. Now, when my pager rings and it says distal radius, I'm like, all right, no worries. I know exactly what I need to get. I know what I need to do. And so that imposter syndrome kind of goes away. But I would say it's normal for everybody. Don't freak out when you feel it. And then the best way to get rid of it is to just get better at what you do. So just keep reading and keep practicing and talk to people who are older than you, like your senior residents or seniors in med school.
So the next question is, how did you decide on a med school and how did you decide on a residency program?
So for med school, I kind of always wanted to go to Columbia. I actually almost went to Brown. They have an 8-year PLME program. So I was actually enrolled in that. And then I last minute like transferred to Duke because I thought it was a better fit for me there. And fit is a really important thing. Like going to a college and a med school that you feel like you fit in at is really crucial to your happiness. And if you're not happy, you won't do well at an institution. So I went to Duke because I felt good there. And I always wanted to go to Columbia for medical school because that's where I received care as a kid with my pediatric congenital heart defect. So I always went to Columbia and I always wanted to go back there. So then when I got in there and they gave me a pretty good financial offer, I was like, it was kind of a no-brainer. And then residency, I basically prioritized the New York area. My family's from the area, my friends are in the area. I didn't really apply to anywhere that I didn't want to live for 5 years. So like Utah, for example, has a great orthopedics program. So does like Rush. And those places just are not places that I want to live for 5 years. So my list, like 1 through 4, were all New York programs.
How were you able to establish a relationship with patients so you could build that trust, but keep distance so you wouldn't get emotionally attached to the case?
In orthopedic so far, it's been okay because it's pretty quick, my interactions. Like I see people, I treat people, and then, it's not like I don't know, a lot of times they get fixed and then they go out. But in medical school, it was harder. I was on a lymphoma service and that was pretty sad. I had a lot of patients that I cared for like 3, 4, 5 weeks longitudinally that then actually passed away. It's hard. There's nothing wrong with embracing your vulnerable side and acknowledging your emotions. But also, obviously, if you're like a crying mess the whole day, you're not really helpful to your patients nor your colleagues. So it's difficult. I would say, take notes of it mentally or actually write them down of the things you feel. Talk about it with colleagues or seniors, and then, go home at the end of the day, call your mom, call your friend, talk it out with them, kind of like express those things and then move forward. It's no use in bottling it up and pretending like you're not feeling things, but yeah.
What was your hardest struggle as a pre-med during your college years?
Mm-hmm. So my pre-med college years, my biggest struggle, I don't know, to be honest, it was probably just balancing everything. It's a lot that you have to do, like do well in all your classes and do research. And then also like, people will say, oh, college is the best 4 years of your life, don't waste it. So just like managing all that and then occasionally feeling like an existential crisis that I didn't want to go to medical school anymore and I should just do banking and do something where I could have more fun with my life, and then getting refocused back towards medicine. That stuff kind of like ebbed and flowed for me. But that was one of the challenges I faced. FYI, guys, for the moderators, I don't mind answering. I see a lot of the stuff about my MCAT score. I don't mind that stuff.
What was your MCAT score, and how did you study for your MCAT?
Yeah, so I took the old MCAT. So I don't really know how the new scoring works, the like 500 scoring. I took the old version and I got a 38. which was good at that score. Doesn't sound good out of like 520, but at the time, I just took a Kaplan class. It was at some like Sheraton hotel in New Jersey that I drove to, took the class. The class was at like a slightly lower level. It was like for everybody. And so my due preparation was pretty good. So I learned in the class, but then I also supplemented it with a lot of like online resources that I found. Taking practice tests is always so helpful. It's a hard test to like understand what they want from you and the type of like science passages and stuff like that. And so just doing more practice tests is really beneficial. But I would say take a class. Like it's there's no harm, you know. They're expensive, obviously, but like if you can afford it, take a class. It's a good structure, and then they have a lot of online resources and extra practice tests.
Wow. Case number 3, what are the chances of infection with this type of injury if you let it heal?
So this guy did get infected, but that was because he was a diabetic with vascular disease. He had on the contralateral side, that ankle was already infected from a previous similar injury and surgery. My attendings like didn't really want to operate. We thought about doing the cast. His bones were not great. Like diabetic bones are soft and too malleable, and they weren't going to stay with just the cast. So we decided to operate, but the skin wasn't great. So that was a kind of like a stuck between a rock and a hard place. Normally, like if this happened to probably anybody in this chat, you know, a youngish person, young healthy person, very, very low risk of infection if you just casted it.
Have you thought about fellowships or, oh yeah, just that. Have you thought about getting a fellowship in the future?
Yeah, so for orthopedics, like 95% of residency graduates do a fellowship, or at least they do one. Some people do 2. I will probably do one. At this point, it's a little early for me to say what I would do it in. Potential things would be sports medicine, shoulder, or trauma are probably my leading 3, but it's really early. I see some stuff on hours. I see some stuff on hardest thing about my job, some other specific questions, but I'll leave them to you guys.
Sorry, there's just like a whole second page we're going through now that I just saw. But what is AOA for a clinical rotation?
Sorry, so AOA is Alpha Omega Alpha. So it's like the honor society for medical school. So it just means usually it's like the people who do the best on their clinical rotations it's like 10% of the class or something like that every year, or 15% of the med school class makes AOA. It's just a distinction, you know, like graduating summa cum laude or magna cum laude or Phi Beta Kappa or something like that in college.
Have you ever felt uneasy when operating?
Oh yeah, not uneasy from looking at like gory stuff. Like I've never gotten like queasy, like I was going to pass out, but more so just not knowing what I was doing because, you know, a lot of these surgeries are very complex and I'm starting out at this. And so I'm in the OR and the attending will just kind of sometimes be like, do this or hand me a scalpel or say, what do you think this is? And I'm just like, oh boy. And I get nervous, but you know, try to keep your cool and be honest with what you feel comfortable doing and what you know and don't know. And yeah.
During your journey to where you are now, did you ever face any failure? If so, how did you overcome that?
I can't say that I faced like a massive failure, but like a lot of small ones of like not doing well on something the first time, having to acknowledge the need for more help in a certain area mentally or like in mental health or in my curriculum, my coursework. Not getting into my first choice for certain things like college. I really wanted to go to Yale. I applied early action there. I got deferred, then I got waitlisted, and then I never got in off the wait list. And so I like was upset about that. But I ended up at a great institution. So again, it's going to be like a lot of failure. This is very like cliche, but they say, on the road to success, there's a lot of failures. It's not just like this. It's like you go up, you go down, you go up, you go down. It's very true. There's just going to be a lot of things that you can't sweat at all. Like you got one bad grade, you didn't get into whatever school you wanted, or you didn't get into some honor society. It just, in the long run, no one small failure is going to like ruin your overall path, as long as you just like keep going forward.
How much time do you spend in the clinic and the OR, like your time schedule on a weekly basis?
So right now, as an intern, I spend most of my time managing the floor. So like the patients that are admitted and the ER consults that come in, I spend maybe 20 to 30% of my time in the operating room. I don't get into the OR necessarily every day. I would say a couple times a week. The senior residents do more operating. So as I'm a PGY, post-grad year 1, 2, 3, 4, 5. So as I'm a 2 or a 3, I'll get in the operating room more. And then clinics, I would say 10% of the time. As we get older, eventually in the program, or as we get more senior, you also have to do some more clinic time to see patients. But right now, it's mostly managing patients on the floor and in the ER.
Before we wrap up, do you have any last-minute advice to our students?
Yeah, I would say think hard about whether you want to do this, and try to make that decision earlier rather than later. So I see it go both ways. I see people who spend a lot of time going towards this goal, which is hard all the way through, and they change their mind and they're like, damn, I wish I knew that earlier, that I didn't want to do this. And then the converse, which is people who didn't want to do this necessarily and then change their mind, and then they have to do a post-bac and they have to take the MCAT after not having studied in college for a certain number of years. So try to, like, it's not always easy. What do you want to be when you grow up? When you're a little kid, you're like, I don't know. And then as you get older, sometimes you're still like, I don't know. But just think about it. And that's where the shadowing really helps, because you get to see what it's like being a physician. And then if you decide ultimately that it is what you want to do with your life, for sure, just work really hard at it, persevere. Don't worry about small setbacks. Just keep going forwards. People always like to see progress. So like poor grades freshman year in a pre-med program doesn't mean that you don't get into med school. It just means you have to do better sophomore year, junior year, senior year. And as long as your grades look like that, people are cool with that. And then get into contact with like everybody. Like be as annoying as you can, because it actually helps you. So email your favorite college and email your favorite med school and get a name of someone in the admissions department. And if you can't find it, find a student you know who goes to that school and ask them who they know in the admissions department, and then email that person and just like get on their radar, because interest matters a lot. I felt like sometimes I didn't get interviews or acceptances from places because they didn't perceive that I was interested, when in reality I actually was, but I didn't convey that. And then also, once you get admitted to places, particularly in medical school, and this is something that no one really tells you, there's a lot of money to be given out, and the squeaky wheels get the most oil. So telling your med school that you really want to go to, that you really want to go there, but you are having trouble financially, and then maybe some other school offered you more money, let them know that. Don't just sit at home feeling distraught about your decision to go to like your local or, state medical school for whatever amount of money less than your private school that you want to go to. Tell that school, and then there's a good chance they say, okay, you know what, we can increase your financial package by X amount of dollars. But like ask, you're not going to receive it if you don't ask. That's my tips.
Thank you so much, Dr. Kantrowitz. We really appreciate you taking time out of your busy schedule to be able to come and talk to us students today. So students, I just want to let you guys know that we are taking applications to join our team. We are a relatively new program. We just launched approximately a month ago. So if you guys are interested in any leadership opportunities, feel free to use this code and it'll take you to the application on our website. I'll leave this up for a couple seconds just in case anybody wants to scan it. Alrighty, and now I'm going to click to the next slide. If you are short on time, we understand that you guys are all pre-meds and that you guys have a lot of stuff going on. If you feel like you cannot commit to a leadership opportunity, there are also volunteer opportunities which are on your own time. and you get to choose your schedule. So you can do it for as many or as little hours as you want. You do it completely remotely from home. And so here's the sign up for that. You can go ahead and scan the QR code or visit our website, pre-health-shadowing/volunteer. Our last announcement is that our next session is going to be with Dr. Joanne Yanez, and she is the Executive Director for the Association of Accredited Naturopathic Medical Colleges. So if you are interested in going the ND route, be sure to register for her session. Her session will be taking place on Thursday, October 15th at 3:30 p.m. Pacific Standard Time. So if you are not in Pacific Standard Time, please take the time zone into consideration. All right, and just to wrap it up, I just want to thank you guys all for joining us here today. Don't forget, if you guys want to get your certificate verifying your hours that you participated in this session today, you really you have to go to our website and take the quiz. The quiz instructions are right here. So once you go into your profile, you are going to click on Dr. Kantrowitz's profile and click Take this course. Once you hit Take this course, you will be led to the module where you can skip through the Zoom meeting since you guys are already in here and go ahead straight to the quiz. The quiz is 10 questions. It's not meant to be hard. If you attended and took good notes throughout Dr. Kantrowitz's presentation, you should be completely set. You will get 15 to 30 minutes to complete this quiz. Once you have finished and submitted your responses, you have to go back to the profile page and click Finish Course. If you do not click Finish Course on Dr. Kantrowitz's page, you will not receive your certificate. Once you do that, your certificate will be made available immediately and you can view it in your profile. If you guys have any questions or experience any issues, feel free to email us at info@prehealthshadowing.com and we'll get back to you as soon as we can. So we are just going to stay on here. This concludes our session. Thank you again, Dr. Kantrowitz. It was an honor to hear you speak today. And we will stick around if anybody has any questions.
All right. Bye, guys.
Thank you.
You're welcome.
Bye, everybody.